case of amputation, then how do you describe the amputation stump? First of all, you describe the time, place and person distribution of the event. That means the identification and demographic data. You ask the question, when were you completely all right, and then what happened, and you record the history. You do a general and systemic examination to detect comorbidities. You determine the socioeconomic status of the person. And the needs for his activities of daily living. Occupational activities, recreational activities, vocational activities, and social activities, socialization. Then you do the local examination of the stump itself. What is the site? What is the length? What about the scar? Has it healed? Is it painful? Is it mobile? What is the status of maturation of stump? I mean, is it going to shrink further or not? Mobility and stability of the proximal joint. And power on the proximal joint. Proximal joints. So, after this, you investigate the patient. For conditions that can lead to an insensate stump, a neuropathic or arthritic joint, and these conditions include vascular or neurological compromise, progressive vascular, neurological or metabolic compromise. Treatment of stump is prosthesis, prosthetic replacement of the lost lower limb. First you prepare a socket by making a negative mold, a positive mold, then creating space for bony points or nerve pressure points, then you apply an inset. Inset means inset or outset, so that the length of the limb is restored and the level of the joint is restored. Finally, you add a Sach foot or a Jaipur foot. After constructing the stump, you do a static alignment. That means you make it stand on the floor and see whether the line of gravity is passing through the base and the stump is not, and the prosthesis is not falling on any side. Then you do a dynamic alignment. That means you make the patient wear the stump, make the patient wear the prosthesis, see whether it is comfortable, it is not hurting anywhere. See that it is snugly snugly fitting. It is not sliding off. See that in the functional position it is bearing the weight at the correct place. See that the prosthetic limb is aligned or symmetrical to the normal limb. See that the joints are at the correct level. See that the person can stand symmetrically on both limbs and on either limb, right and left, stably. See that he can sit on a chair, sit cross-legged or squat if the prosthesis allows it. Then see the patient while he is walking. Carefully note the position in heel strike, foot flat, tibial alignment, femoral alignment, toe break push off, swing to, swing through, deacceleration, see if the prosthetic limb, how the prosthetic limb is different from the normal limb. If it is different, you adjust the prosthesis till there is no difference. Then you gait train the patient, first on parallel bars, then on bilateral axillary crutches, then on elbow crutches, then on 2 walking sticks, then on 1 walking stick, and then without walking stick. Subsequent to this, you certify the disability of the patient so that he can take advantages of the disability support by the government. You do occupational rehabilitation, vocational rehabilitation, socio-medical and recreational rehabilitation. By finding out what is optimal, achievable for the patient, what is his present status, and trying to maximize the closeness of the status to the optimum. Now the other questions asked are, what are the causes of amputation? The causes of amputation are injury, paralytic limb, vascular compromise, insensate limb, infections dangerous to life, non-functional status of limb, where it is a bigger problem, bigger unsolvable problem than support, and congenital limb deficiencies, where the amputation is congenital.
Malignancy.
Malignancy. When you decide to amputate in these conditions, at least 2 surgeons must decide. And there must be an informed consent. The procedure can be emergency life-saving or elective to improve function. After assessment of fitness for anesthesia and surgery, patient is under anesthesia. Part preparation and draping is done. The level of amputation is decided. Basically, it is 20, 10, 30, 15. 20 is arm, 10 is forearm, 30 is thigh, and 15 is leg. So this is in centimeters. And this is the level of bone section. Supposing this is the bone and this is the soft tissue, from the center of the bone, you want to cut the soft tissue in a manner so that there is a 45-degree angle here. And when this will close, you'll close this first, and then you'll close this like this, so that this becomes like this, and here is the bone section. So your stitches would close it like this. First, the periosteum by a purse string suture, then the muscles, the fascia, the subcutaneous tissue, and the skin. Now, what are the various amputations? So there is a 4-quarter amputation in the upper limb, where the pectoral girdle is removed. There is disarticulation of shoulder. There is amputation through the arm. There is disarticulation, elbow. Then there is what is in the forearm. There is a amputation through the forearm. And there is a very, very special amputation through the forearm, which is called as Krukenberg's amputation, where you use the radius and ulna as pincers to catch, to grasp, to substitute for the pinch and the grasp of the hand. So this will be the radial flap and this will be the ulnar. And you will be moving at the radio-ulnar joint. The radio-ulnar joint. Right? Then there is through the wrist. And of course, thumb, fingers. Then there is the hind quarter. amputation, disarticulation hip, above knee amputation, disarticulation knee. You remember that AK is better than disarticulation through knee because AK amputation allows you to place a knee joint. Then there is a below knee amputation. And the prosthesis to the below knee is conventional below knee, where there is a thigh corset. Then there is a PTB, patellar tendon bearing. Then there is a PTS, suprapatellar tendon bearing. And there is a bent knee. Supposing there is a flexion deformity of the knee, then there is a prosthesis which adjusts for that flexion deformity. So there is a bent knee prosthesis. Then after that there is the Symes, and then there is disarticulation through the ankle, and there are amputations of the foot. All right. One is subtaloid, then mid-tarsal, and then metatarsophalangeal amputation. So these are basically managed by shoes. In subtaloid amputations, in the lower limb amputations, you have to ensure that the plantar flexor and dorsiflexors are intact. So if you do amputation here, only plantar flexors will remain. Therefore, this calcaneal stump can be turned and put into tibia, can be turned like this and put into tibia, or can be straight away fused with the tibia. So these are the two types of amputations where the dorsiflexors are lost. Okay, because then you have to manage the plantar flexors. So these are the various types of amputation that you do. How do you give that incision? So the incision, supposing this is the level of bone section, the incision would go like this, all around it, and like this, all around. This will be equal to the radius of the stump. So radius here, so it becomes the diameter. So this is the radius. And normally the angle between the two flaps must be about 45 degrees. Then I have told you that if this is the stump, the periosteum may be stitched like this. Or you have to do a beveling of the stump, especially if the angle is subcutaneous, beveling. The third thing you can do is what is called as myoplasty, right? You are using the muscle also. So you use the periosteum and you are using the muscle also. And finally, there is something which is called as osteoplasty, where this is longer and this sort of closes the medullary canal. Post-operatively, you can do what is called as an immediate post-operative prosthetic fitting. It prevents infection. It prevents swelling. It increases maturation. It prevents phantom limb sensation. And it promotes early ambulation. So these are the advantages of immediate post-operative prosthetic fitting. Here you attach a pylon to the socket, to the plaster socket. So this is immediate post-operative prosthetic fitting. I think if you know this much about amputation, it's enough.
And sir, how to confirm that the stump has matured?
The method of confirming is that till a fixed point, you dip the stump in water and see the displacement. So there's a volume, and when the volume in two readings 2 weeks apart comes to be constant, that means it's not decreasing. You say that the stump is matured. Otherwise, you fix a time and say that any stump would mature in 6 weeks. Okay? Anything else?